Hello, everyone. Welcome to the Department of Medicine Grand Rounds. Today is a little bit of a different and special Grand Rounds because we have three speakers who are all the winners of our recent University of Miami Research Day. We're going to be having Dr. Wang present first, followed by Dr. Jacobsen, and Dr. Ocejo will finish us off. I'll first introduce Dr. Wang. Dr. Wang earned his bachelor's degree from Rutgers University prior to attending medical school at Nova Southeastern University, where he also attained a master's of public health. He then returned to Rutgers, where he completed internal medicine residency. Following a chief resident year, he completed his Hem/Onc fellowship at Temple and further fellowship training in adult stem cell transplantation and cellular therapy here at the University of Miami, where he has now remained as an assistant professor. He continues to work here at the University of Miami as the site principal investigator in multiple clinical trials, assessing treatment options in graft versus host disease, as well as in stem cell transplantation. Dr. Wang?
Thank you so much. Today I will be discussing steroid refractory graft versus host disease, including its management, as well as our group's data on the use of Vedolizumab in this steroid refractory setting. Credit has to go to Shreya Shah and Dr. Amer Betanjani and the rest of our pharmacy team who are instrumental in working on this project. Also to Dr. Lazarus Lekakis, who was the one who actually started using Vedolizumab in this particular treatment setting. So in this presentation, I'll be providing an overview of allogeneic stem cell transplant, as well as the steroid refractory graft versus host disease diagnosis and general management. I'll talk about Vedolizumab's role in this, as well as our retrospective data. And then I'll talk about a very important milestone in the transplantation field, which is the approval of ruxolitinib. So allogeneic stem cell transplantation is the only curative therapy for many advanced heme malignancies, such as high risk or relapsed refractory leukemias and lymphomas. And transplantation combines two therapies, really high-dose chemotherapy or radiotherapy, as well as a new donor immune system that's able to restore cancer surveillance and killing through an immunotherapy effect. While that's a desired effect, there's also these off-target effects where the alloreactive immune system now can attack normal recipient organs, and this is what we call graft versus host disease. So this figure on the left is from a Center for International Blood and Marrow Research study published in 1990 by Mary Horowitz, which demonstrated retrospective outcomes of patients with acute myeloid leukemia and chronic myeloid leukemia who underwent allogeneic transplant based on the type of their graft and the presence of GVHD. And this is a chart that shows the probability of relapse. So at the very top of this chart, we see that twins and those with T-cell depletion had the highest rates of relapse of their underlying cancer due to HLA similarities or the lack of these T cells. And then this relapse rate really diminishes as people were found with a diagnosis of either chronic GVHD or acute GVHD or the combination. Statistically significant differences. And this study supported the important role of the graft versus cancer effect, as well as the difficulty in separating that effect from graft versus host disease. So acute GVHD is present in about half or more of transplant recipients, and among those treated, there's an unmet need because less than 50% of these patients achieve a durable response to treatment and frequently need more. So the clinical manifestations of acute GVHD are depicted here. There's a wide spectrum. Liver GVHD is manifest classically as an elevated bilirubin level, but can also involve transaminases. Dermatitis can be mild, faint, blanchable, and treated with topical therapy, or it can be severe, progressing to erythroderma, bullous formation, desquamation, like in this image here. And there's enteritis, which can be upper GI involvement with nausea, satiety, cramps, or lower GI involvement with diarrhea, ileus, GI bleeding. Volumes of diarrhea can even exceed 2 liters a day or more. It can be very severe. So grading for graft versus host disease is based on clinical severity of organ involvement. This is one example of the Minnesota Refined Risk Score, which is one of several systems used, and demonstrates how the treatment-related mortality differs based on the extent of involvement. standard versus high risk here is defined based on the number and severity of organs. And I'll give you the example for GI GVHD because that's relevant to this talk. But for any GI GVHD above stage 1, which means anyone who has more than 500 milliliters of diarrhea a day is considered high risk. And that's practically all of our patients that we're talking about. And these high risk patients on this scoring system had a 6-month treatment related mortality estimate of 44%. I mean, that's astronomical. Almost half of patients were gone at 6 months. Many of these patients also develop steroid unresponsive or what's called steroid refractory GVHD, or I'll call it SR-GVHD in short. This is defined as progression after 3 days of steroid treatment or a lack of response after 7 days. And this population requires more therapy, additional immune suppressive drugs. And as a result, to emphasize the above statistic that I just discussed, 6 months survivals on the order of as low as 49%. So the treatment for SR-GVHD up until very recently was a hodgepodge of agents without a clear pecking order. Each institution did their own thing, and even within each institution, there was a lot of heterogeneity. Nothing proved superior for over 50 years until 2019, when we had the approval of ruxolitinib, which is a JAK1/2 inhibitor, which likely works on the dendritic cells, neurophages, and macrophages, and really modulates cytokine signaling. But this, I'll come back to this chart later in the presentation. But just for a visual, there's a lot of therapies, but not much proven, except for really ruxolitinib. So that brings us to vedolizumab, which is one of the agents that has been of interest to transplant physicians for a while. It's an appealing drug to us because in the setting of SR-GVHD, this drug blocks binding of alpha-4 beta-7 integrin on the T cells to MAdCAM1, or mucosal addressing cell adhesion molecule 1, which is expressed on endothelial cells of the gut, including the Peyer's patches and enteric lymph nodes. And essentially, this blocks migration of lymphocytes from the blood into the gut. So this drug is FDA approved already for the treatment of Crohn's disease and ulcerative colitis, which makes it accessible. And the organ specificity towards the gut potentially spares more toxic or globally immune suppressive effects, which is always a concern in our population because of opportunistic infection. So there's been many published small series on the use of vedolizumab in SR-GVHD, and there's a lot of mixed efficacy reports. Some, from as little as 5 patients, maybe 2 of them had a small response, but others show that it can improve survival in a good proportion of patients, and there's always data supporting both sides in our field. So I will add that there is one prospective phase 1 dose-finding trial that was conducted and completed by the sponsor, the company that makes vedolizumab. This study enrolled a total of 17 patients and was stopped early due to lack of efficacy, although their data was never published, and this study completed enrollment over 1 year ago. So we'll see if they ever publish this. This information was only found on clinicaltrials.gov. In our study, we retrospectively looked at post-transplant patients who had steroid refractory GI GVHD from November 2017 to March 2020, who received at least 1 dose of vedolizumab, all off-label as emphasized, and we wanted to see how they fared. We identified 14 patients, half of whom were male with a variety of different heme malignancies. The majority of them had HLA-matched transplants, most of which were myeloablative or strong chemotherapy conditioning, also a risk factor for severe GVHD. Most of these cases had at least GI involvement, and many with concurrent skin or liver, and were all treated with systemic corticosteroids initially, which is a standard of care. At the initiation of vedolizumab, everyone had GI GVHD, with the majority of them having a high clinical stage. So stage 3 up here represent 29% of patients. And stage 3 really means that these patients are having more than either 7 bowel movements of diarrhea a day or 1,500 milliliters of stool a day. That's a lot. Stage 4, which is even a bigger chunk, had more than 2 liters a day. severe abdominal pain that was refractory, GI bleeding, ileus, or something very similarly bad here. So these were very sick patients. The median number of vedolizumab doses was 3, and you can see how the dosing usually works, which is basically according to the label for the FDA-approved indications. And vedolizumab here in our cohort was frequently used in combination with other agents, which we defined for the purposes of our series as concurrent initiation of another agent within 7 days of vedolizumab start. Sometimes this was because of GVHD manifestations that were outside of the gut. So we see that vedolizumab was also not the first salvage treatment for patients, and frequently second, third, or later line as combined with these other agents. Our primary endpoint was overall survival at 180 days. We know that 6-month survival is classically very poor here. We found that 57% of our patients were still alive at this time point. Response, or really more accurately called failure-free survival, which is defined as being alive without relapse, without requirement of more agents for immune suppression, at 30 days was 83%, at 90 days was 56%, and at 6 months was 38%. During this time, we were able to reduce the corticosteroid doses. And this is critically important because we think that corticosteroids are one of the major contributors to infection. However, even still, the infections were, which we defined as any documented new bacterial, fungal, or viral diagnosis, was seen in 64% of patients, and that's a total of 14 infections in 9 patients. This included things like candidiasis, esophageal candidiasis, fungal pneumonias, CMV or adenovirus activations, bacteremias, you name it. In a steroid refractory GVHD group, this is expected to be relatively high. Another retrospective study looking at vedolizumab found their infectious complications in over 80% of patients. So this is probably due to the underlying immune dysregulation and corticosteroid use, but of course it may have an effect from these additional agents we give. So what does all this data mean? We'll take it in the context of this REACH-2 trial, which is the one that supports ruxolitinib. This is actually the second trial for SR-GVHD. REACH-1, which was a phase 2, a smaller study, actually supported FDA approval. But REACH-2, this one, is a prospective phase 3 randomized unblinded trial, which compared ruxolitinib to best available therapy. And on this protocol, investigators had a choice of over 9 options that their institution was comfortable with, similar to what we showed on that massive slide with all the choices, pick your own adventure choices. So over 300 patients were accrued, about 152 per group, and their primary endpoint was overall response rate, which demonstrated superiority at the day 28 point compared to the control group, so 62 versus 39%. So more strikingly, ruxolitinib demonstrated improved failure-free survival. Again, that means people were alive without disease relapse and without requiring or failing ruxolitinib and requiring more therapy. So this curve on the left shows a failure-free survival with nice separation of the curves. A median failure-free survival is 5 months versus 1 month in the best available therapy group. Overall survival was not statistically different, with a confidence interval shown 0.6 to 1.15. However, the curves look pretty separate in the first few months, and the way this trial was designed, they allowed crossover into the ruxolitinib group, and about 1/3 of patients did end up crossing over. So ruxolitinib was the first drug in the SR-GVHD space to demonstrate superiority in a randomized trial and has earned its place as a first-line agent for steroid refractory GVHD. It has its share of issues as any drug, including one, it's oral. So in critical illness or when there's concerns about absorption, we're not totally sure that it's getting where it needs to go. It also has a lot of cytopenia-related toxicities, which is already something we see in these GVHD patients. And finally, the infectious disease profile, while not shown on this slide, was very similar, not dramatically increased, but not lower than that of best available therapy. So still with relatively high rates of these severe infections that often cause the demise of GVHD patients. So in conclusion, vedolizumab demonstrated relatively good tolerance and relatively good survival. Everything is relative here. We are able to reduce corticosteroid doses, but we frequently had to combine this drug with others. And there are still plenty of infections. Extraintestinal manifestations are not covered by vedolizumab, at least we don't think they are. So that's a concern if they improve in the gut but get worse elsewhere. And that in our series, we had ruxolitinib as the combination partner in many cases. So where does vedolizumab fit in this ruxolitinib world? We don't exactly know. But prospective clinical trials are continuing to be run here. And of course, we think that the emphasis needs to be on prophylaxis rather than treating something that's already developed. And that is actually where the current development of vedolizumab is. It's being combined with conventional GVHD prophylaxis regimens, early transplant, to try to prevent this from happening. That's all. Thank you.
Thank you, Trent, for putting that together. It was very clear, very nicely stated. If you were to design your own agent, how would it differ from the current one that you tried, vedolizumab? What would you want to change about it?
That's an interesting question. Really, I think these agents tend to have efficacy. So efficacy isn't the major problem a lot of times. It's that the efficacy comes with its share of immune suppression and the treatment-related toxicity. So that separation is the key. We need to figure out how to not put you at risk for CMV virus and the sorts while still being able to control what's going on with the tissue damage.
Thank you, Dr. Wang. Dr. Corbett, please continue.
Thank you, Dr. Wang. Our next speaker is Dr. Jacobsen. Gillian Jacobsen received her bachelor's degree in microbiology from the University of California at Berkeley. She worked in both biotechnology and academic research before joining the Medical Scientist Training Program, which is an MD PhD program at the University of Miami. After completing her first 2 years of medical school in the program, she has now joined the Abreu lab for her PhD. Her research focuses on the microbiome and immunopathogenesis of inflammatory bowel diseases. Gillian?
Hi, let me share my screen. Hold on one second. Okay. So hello, everyone. Thank you for the introduction. Yes, my name is Gillian Jacobsen. I'm an MD PhD student here at UM, and I'm currently in the Abreu lab here. And today I'm going to be talking about targetable gene expression of gut phagocytic immune cells and whether they're potentially the key to unlocking IBD. I have no disclosures, and these are my mentor's disclosures. So inflammatory bowel disease is a chronic inflammation of the GI tract, and it includes both Crohn's disease and ulcerative colitis. Symptoms can include diarrhea, rectal bleeding, and abdominal pain, sometimes severe. Crohn's can occur anywhere from the mouth to anus. It's usually in patches, and typically the most common site is the terminal ileum. Whereas ulcerative colitis tends to begin near the rectum and work proximally in a continuous manner. And some other clinical characteristics of Crohn's is the fat wrapping or creeping fat, full thickness fissures, as well as this cobblestoning appearance. Whereas in ulcerative colitis, we see more of a surface level ulceration, and you can get these pseudopolyps that form from the remaining mucosa. So what causes IBD? Well, in the search for a singular cause, scientists have discovered many associated factors, and this has led us to believe that IBD is multifactorial. So that includes genetic polymorphisms, of which there are over 240 loci associated with IBD. Epigenetics, which includes DNA methylation and microRNA that can affect gene expression. The microbiome, which begins colonizing the gut at birth from the mother, and also throughout life from the diet. And other environmental factors like diet, antibiotic use, other drugs like NSAIDs can disrupt the mucosa, certain pathogens, and other stressors. And all of these things can lead to intestinal inflammation, which may become chronic as IBD. If we look a little closer on the molecular level, these are the few things that we do know about IBD. So one is that the gut microbiome is affected. In IBD, there's a reduced diversity and a loss of what we consider good bacteria and a relative ratio of higher bad bacteria. And this is termed gut dysbiosis. There's also a damaged epithelial barrier function, sometimes called leaky gut. And there's a resulting immune dysregulation with an influx of both innate and adaptive immune cells and a chronic inflammation, pro-inflammatory cytokines, et cetera. So while we don't know the root cause, we have been able to target specific aspects of this inflammation in order to treat IBD symptoms. So this includes anti-cytokines, anti-TNF agents, JAK inhibitors, S1P inhibitors, and anti-integrins. A few of you may recognize these drugs, especially the anti-TNFs that are used for IBD, as well as many other autoimmune diseases. Dr. Wang in the previous talk actually mentioned Vedolizumab, and JAK inhibitors are some of the more recent drug classes that are being used. And the asterisk denotes those that are still in clinical trials. So while many treatment options exist, they're not perfect. And there's a high rate of refractoriness in patients with anti-TNFs, especially up to 40%, either do not respond initially or lose response after initial response. And so because of this, we're still trying to figure out really what the best treatment option is, since there's no one size fits all. There's a lot of trial and error for many patients. So in our continued search for a better understanding of both IBD pathogenesis in general, as well as response to drug therapies, my lab has decided to focus on a particular cell subset, which is the phagocytic immune cells of the gut. So these cells reside just beneath the epithelium within the lamina propria, and they're the first to encounter the gut microbiome. So they're termed phagocytic because they engulf these microbes. After that, they can process them and present them to other immune cells. They're also known to have altered cytokines and bacterial clearing defects. And interestingly, they all have this common CD11b marker, which we can use to isolate them and study them. So in our lab, we have asked these questions. One is, do phagocytic immune cells behave differently depending on disease status, meaning do they behave differently from Crohn's disease and ulcerative colitis? Do they behave differently from inflamed tissues versus uninflamed, et cetera? And do they hold the key to understanding IBD pathogenesis? And furthermore, we asked, do phagocytic immune cells from anti-TNF refractory samples behave differently than those from uninflamed? So do patients who have refractoriness to anti-TNFs, do their phagocytic immune cells have some special characteristic that is different from other people? So in order to answer these questions, we obtained mucosal biopsies from a diverse set of IBD patients, including those on anti-TNF therapy. And these are patients from all levels of disease, some very, very mild in remission, others very severe. And this was all thanks to our Crohn's and Colitis Center physicians. Next, we isolated the CD11b positive cells from the lamina propria, the phagocytic immune cells. And then we extracted RNA and performed RNA sequencing. And this allows us to analyze the RNA transcripts and better understand which genes are being actively expressed by these samples. And we can then compare samples to one another. So in our first set of results here, you can see this is a pie chart of, a Venn diagram of all the different differentially expressed genes across three main comparisons. So this is comparing, for example, all of the colon samples to all of the ileum samples, all of the ulcerative colitis samples to all the Crohn's samples, and all of the inflamed to the uninflamed. And how many genes are being differentially expressed, either higher in the inflamed or uninflamed, and vice versa. And as you can see, there's a high number in the colon versus ileum, especially compared to the other two comparisons. So this is telling us that the most differentially expressed genes are actually dependent on the tissue location of origin. And that you can also see here in this principal component analysis. Each dot represents a different sample, and the samples are clustered based on how similar their gene expression is. And as you can see, the colon is all orange. Those samples from the colon are orange and samples from the ileum are blue, and they form pretty distinct clusters, meaning that cells coming from these areas are very distinct in their gene expression. But there's less distinction when you look at CD versus UC or inflamed versus uninflamed. There's some distinction in the ileum, but not as much in the colon. So then we took all of these genes and we mapped them to pathways using Ingenuity pathway analysis. And in this heat map, each column is a different sample comparison. So we have, again, colon versus ileum, inflamed versus uninflamed, etc. And each row is showing how highly expressed this pathway is in each comparison. So if the color is orange, it means that it's highly upregulated, and if it's blue, it's downregulated. So, for example, in colon versus ileum, we see a lot of orange in these immune system pathways, meaning that in the colon, there's more immune system pathway upregulation, whereas we see blue in these metabolic pathways. And blue can either mean downregulated in the colon, or in this case, upregulated in the ileum. So that makes us believe that these metabolic genes that are upregulated in the ileum are likely helping out with metabolism and digestion, which it takes place in the ileum. Whereas the inflammatory pathways that are happening in the colon might be due to the fact that the microbiome is much denser in the colon than the ileum. And then perhaps the most interesting comparison was this inflamed versus uninflamed in all of the samples from the ileum that are on anti-TNF therapy. So this is essentially comparing those that are inflamed on anti-TNF therapy, meaning refractory, to those who are responding to anti-TNF therapy. And as you can see, there are many pathways that are upregulated in these non-responders. So these include ones I want to point out, like TREM1. So TREM1 is actually a known biomarker for anti-TNF non-response. So if it's high in patients before undergoing treatment, it can actually predict that they will not respond well to anti-TNF therapy. Another one is the STAT3 pathway. So this is part of the JAK-STAT pathway, of which the JAK inhibitors target, and that includes tofacitinib that I mentioned earlier. So overall, we think that some of these pathways could serve as other biomarkers or potentially other targets for new drugs in the future. Lastly, we took a further look at the STAT3 pathway that was upregulated in these anti-TNF refractory samples. And we saw that these cytokines and these receptors that were upregulated all converged on JAK2. And this is interesting because tofacitinib, which I mentioned earlier, that is approved for IBD, targets JAK1 and 3. It doesn't target JAK2. There is a drug that exists, which Dr. Wang also mentioned in his talk, ruxolitinib, which is a JAK1 and 2 inhibitor, but this is not currently used to treat IBD. It's used in myelofibrosis and polycythemia vera, and apparently graft-versus-host disease. So what we wanted to look at was to see how do these compare in preventing inflammation from these, an inflammatory response from these phagocytic immune cells. So we took the isolated phagocytic immune cells and we cultured them with LPS, which is a potent activator of inflammation. And we also cultured them with either ruxolitinib or tofacitinib. And we then measured TNF alpha and IL-8, which are pro-inflammatory cytokines that are prevalent in IBD. So overall, LPS induced cytokine release across all of the samples, yet those treated with JAK inhibitors had a decreased cytokine production, especially those treated with ruxolitinib. So as you can see, the TNF alpha was significantly reduced with ruxolitinib, as well as the IL-8 was more significantly reduced than with tofacitinib. So overall, this is showing that JAK inhibitors are effective at modulating inflammation in these phagocytic immune cells. And there is some evidence that JAK2 may also be a good target in IBD, even though it has never been used before. So in conclusion, our research has shown that phagocytic immune cells of the gut are more immunologically active in the colon, likely due to the microbiome, whereas in the ileum, they may have a role in metabolism or digestion. And those phagocytic immune cells that are in anti-TNF refractory patients have an increased JAK2-associated gene expression and decreased cytokine production when cultured with a JAK1 and 2 inhibitor, such as ruxolitinib. And they also show upregulation of other targetable immune pathways like STAT3, TREM1, and others, which could act as biomarkers or future targets for treatment in refractory IBD patients. So I want to thank everyone in the Abreu lab, especially my mentor, Dr. Abreu, our collaborators, the MSTP, and of course, the Department of Medicine for having me today. So thank you very much.
Gillian, thank you for that excellent talk and the exciting, presenting this exciting research. Though your hypothesis that the immunoreactivity is higher in the ileum than in the colon, and you say that that's because of the microbiome. Is there any proof of that other than the fact that it's guilt by association? In other words, are there experimental models such as mice that don't have the lactome components that have a different profile, or is there some other data that you have for that other than just guilt by association?
No, you're exactly right. That was more speculation on our part. Although we did notice that in the colon there is a higher inflammatory response gene expression. It was pure guess that had to do with the microbiome. And I think that's actually a really good idea to confirm in mice. Like you said, we have our germ-free mouse facility that we run that we could have definitely used to confirm that. So that's a great point that you bring up.
Great. We have time for another question or comment. Dr. Abreu, I see you're sitting on the edge of your seat, but still muted. Do you want to say something?
No, that was awesome. I'm a little biased, but it was awesome. I see a question from a question from Dr. Lakakis that I don't think my brilliant graduate student will know the answer, but curiously, IL-17 blockers actually worsen Crohn's. Even if you watch the ads for these, they'll say it at the end of the ad that it can worsen IBD, which is kind of interesting, right? Because IL-17A is very much upregulated in inflammation, but apparently blocking it is possibly disrupts the barrier. whereas IL-23 inhibition is beneficial. So go figure. It's in the go figure category.
Exactly, because ustekinumab indirectly blocks the IL-17, the
Right.
Th17 by inhibition of IL-23. So I was wondering a more direct inhibition of IL-17, but you answered my question.
Yeah.
Thank you.
Thank you very much. Oh, you wanted to say something, Doctor?
Oh, yeah, I was just going to say that it's interesting because IL-6 is also upregulated in our data. And I checked to see if there were any IL-6 inhibitors that were being tested. And again, it's the same thing that Dr. Abreu said. It also worsens IBD, at least in a mouse model, to block IL-6. So really interesting, all the mystery that goes on there.
Well, I'm sure you'll solve the mystery before you graduate, Miller. So we're grateful. Dr. Corbett.
Thank you. And thank you again, Gillian. That was great. Our final speaker today is Dr. Ocejo. Dr. Ocejo is a current internal medicine resident here at University of Miami who comes to us from Mexico, where he obtained his medical degree from Universidad de Sonora. His career goals include hematology oncology, and he hopes to complete a fellowship in that following completion of his residency training here at IM at UM. Okay, Dr. Ocejo, you want to get started?
Thank you. I'm going to share my screen now. Okay. Good afternoon. Thank you, Kelly, for introducing me. Thanks for the invitation to present at Grand Rounds. It's an honor to be here and to talk about the clinical vignette of our patient. First and foremost, I want to thank my colleague and friend and my senior resident, Filipos, who gave me the opportunity to work on this case, and to Dr. Hakim, our pathology resident who helped us kindly review the slides on this patient. So the clinical vignette is on our patient who had an extraskeletal osteosarcoma of the pelvis with near complete response to neoadjuvant chemotherapy. So the learning objectives of this clinical vignette are to recognize the potential of osteosarcoma type neoadjuvant chemotherapy, because there's no specific role elucidated for chemotherapy in this type of cancer that is very rare, along with radiotherapy in its extraskeletal form, and to identify the distinct features in response to treatment and prognostic factors compared to the more common but still rare skeletal osteosarcoma. So we know that historically, patients who present with localized disease of this cancer have been treated with surgical resection. Radiation is often employed in persons who have margin positive resections, but we don't really know what's the role of chemotherapy in this type of cancer treatment. So it remains controversial. So also the chemotherapy regimens employed in these patients with these tumors are typically those utilized for soft tissue sarcomas rather than for skeletal osteosarcomas, which utilize more like platinum-based chemotherapies. So starting with the case presentation, the patient is a 33-year-old woman, initially presented to the ED with a chief complaint of symptomatic anemia, secondary to abnormal uterine bleeding. She had associated unintentional weight loss of more than 40 pounds in the past 2 months. She also had a past medical history of depression and chronic abnormal uterine bleeding, never requiring blood transfusion, so it wasn't that bad until she got to the ED, when labs show a hemoglobin of 5 and an hematocrit of 15.7%. She received several units of PRBCs, and after several imaging techniques, they eventually did a MRI of the pelvis, and it revealed a large heterogeneous pelvic mass measuring up to 16 centimeters, but the mass was invading the right pelvic side wall invasion, and there was extension of the tumor into the pelvic musculature, so it was deemed not resectable. I have an image here of the mass, which I'll describe a little bit later. So they eventually did a biopsy of this mass, and rubella malignant high-grade sarcomatoid neoplasm with osteosarcomatous differentiation. So this was interpreted as an extraskeletal osteosarcoma. And they eventually did next generation DNA sequencing on these biopsy tissue. And they found this loss of function mutation in the gene TP53 and deletion of genes CDK and 2A and 2B, which are, the cyclin-dependent kinase inhibitors. Those are tumor suppressor genes that, when alterated, might predispose to malignancies. And they're also present in the several other types of neoplasms as well. So this might give us a clue why she had such an outstanding response. So these are two microphotographies of the biopsies that was done on the mass. The first one here is, we can see the neoplastic bone formation, the coarse seams of osteoid. We see the osteoid formation here and formed by the pleomorphic malignant cells. Pleomorphic just means that varieties in size and shapes and stains, and it's all part of the malignant cells. And here in this microphotography, we have, say, the malignant cells here, in direct opposition to the osteoid formation, which is like the premature stage of the bone matrix. And this is a mass that it was found on the MRI of the pelvis in this young patient. So we see that it's heterogeneous with scattered cystic areas. It measured up to 16 centimeters in diameter. And like I mentioned, the presence of right pelvic sidewall invasion and the extension of the tumor into the pelvic musculature. So eventually she received neoadjuvant therapy with vincristine, doxorubicin, and ifosfamide. That's the VAI regimen. The therapy was truncated after she developed severe ifosfamide-induced encephalopathy, Fanconi syndrome, profound cytopenias related to the whole pelvic radiations that she eventually had to have because of the profuse uterine bleeding. So all cycles were complicated by neutropenic infections, but at the end, the major toxicities were worth it. We're going to see the comparison of the two MRI scans before and after. She also underwent preoperative stereotactic body radiation therapy to the pelvis. And the patient is expected eventually to be a surgical candidate for tumor resection after she had the outstanding response to the neoadjuvant chemotherapy. We can see here the difference and the regression of more than 90% of the tumor. And the right, we see the MRI pelvis that was done 6 months later, showing the decrease in size of the pelvis, of the pelvic mass, centered in the right aspect of the upper vagina, with less than 5 centimeters in diameter, really. Still, there was a little bit of a sidewall invasion, pelvic sidewall invasion, but no encasement of major arteries like the right inferior gluteal or other major significant vessels there. So talking about a little bit more about this, this rare cancer. So this is rare soft tissue sarcoma with histologic similarities to primary bone osteosarcoma. The only thing that makes this different is that it's not attached to either bone or periosteum. So that's why it's called extraskeletal. Epidemiology, very rare, less than 2% of all soft tissue sarcomas. And within the osteosarcomas, it's even less than 4%, the presence of this cancer, of this tumor. It typically affects patients who are older, between 50 and 70%, 70 years of age. That's compared to the primary osteosarcoma, which affects primarily young adults. And the reported male to female ratio is 2 to 1 almost. So like I was saying, the treatment, the treatment of choice is wide margin surgical resection. Also, some data support the view of treatment with an osteosarcoma type chemotherapy, mainly consisting of doxorubicin and ifosfamide. Pre and post post-operative therapy has been used as well, especially if the tumor had positive margins after resection. But there's no still consensus of the role in the role of chemotherapy. Of course, this tumor has unfortunately poor prognosis. The 5-year survival ranges from 10 to 46%, and more than 50% of patients experiences recurrences and distal metastasis, the most common being to the lungs and regional lymph nodes, brain, liver, skin, and bone. And the large tumor size and higher histologic rate, of course, like in most cancers, indicate a lower overall survival rate. Thank you so much.
Thank you, Antonio, for presenting this interesting case, rare case. Oftentimes from rare cases, they can be informative of more general aspects of medicine and biology in general. I'm intrigued by your discovery of the TP53 mutation. Is this, and presumably, I guess that's a good prognostic sign for its response or for responsiveness. Is this something that's looked at routinely in sarcomas, or is it something you should be? And if you want to defer the answer of this question to Dr. Trent, the world's guru in sarcomas, I would certainly understand. But if you want to take a stab at it yourself, go ahead.
I can try to answer. I think that's well, the specific like loss of function mutation that was discovered in this patient, I believe they always do TP53 in next generation DNA sequencing, but I don't know if this specific loss of function mutation was particular to this particular patient. But the other curious finding is the CDK 2A and 2B deletion and this tumor suppressor genes. So I'm not sure if this is going to dictate for therapy, to be honest.
Dr. Trent, would you like to thank you? That was a good answer, Antonio. John, do you want to respond?
Yeah, and Antonio's pretty much on target. We don't really know. P53 is involved in DNA damage repair. And so when P53 is lost, it can portend sensitivity to DNA damaging chemotherapy like doxorubicin and ifosfamide. But at the same time, it's an oncogene that is generally associated ultimately with poor outcome, higher metastatic potentials, and so it's a little bit of a mixed bag. It's an important, it's important to recognize in sarcoma. And then there are osteosarcomas that are hereditary in the setting of Lee-Fermini syndrome, where there's germline loss of P53.
Thank you, Dr. Trent. Any other questions? Well, I want to thank everybody for staying on Grand Rounds and showing support to these three very special individuals, who not only because they won in the research day, but they really represent the three different stages of embryogenesis of our next generation of faculty. We have someone who's an MD PhD student, we have somebody who's a resident, and we have an accomplished junior faculty member in reverse order as it was presented. And I think that the Department of Medicine is grateful to be able to provide a platform for showing the very best science that our trainees can do. And I hope to see more of it in the future and encourage you all to expand your creative wings and research wings in all areas, not just translational science and medicine, but all aspects of medicine. So thank you once again. Don't forget to sign in for CME, and look forward to seeing you next week. We are off because of the Passover holiday, but then the following week we will resume Grand Rounds. Wishing everybody a safe day.